Welcome back, everyone. We're going to get started. We're only running about 10 minutes behind. That's not bad. I'd like to introduce Dr. Randy Vince. He is the Director of Minority Men's Healthcare at the Cutler Center for Men at University Hospitals. And some of you have had the pleasure of hearing him here before. So he is going to talk about genetics and prostate cancer.
All right, good morning, everyone. Can everybody hear me okay? All right, sounds good. All right, well, it's a pleasure to be here with you all this morning. Mary, I appreciate the invitation. As you know, the Gathering Place does amazing work, so anytime you guys need me, please know that I'm there. I hope you know that already. So I have the task of discussing the role of genetics in prostate cancer. The way I designed this, I tried to, because when we start talking about genetics, you know, sometimes we can get a little dense with the scientific stuff, and so I tried to just minimize that and just give you some points to think about and to take with you, and ways that you can also discuss that with your family members. So with that, I'll go ahead and get started. So they make us do this in academic medicine. I don't have any disclosures that are relevant to this presentation. These are some of the objectives that I'm going to try to accomplish today with this presentation. So, you know, I'm sure you guys have heard about like things around the incidence and mortality of prostate cancer. But when we start talking about genetics, you know, we can often split that up into two things, either germline or somatic, so we'll review that. And then the role of genetic testing. And then within genetic testing, I also put what we call genomic testing, which also helps with precision medicine. And forgive me, I like to walk when I talk, but I can't go too far away from this laptop, so that's the reason I kind of keep doing this motion here. So, but I know there's plenty of people who I've met here already. Some of you I have not met, so I'll just take a couple of moments to introduce myself. Again, I am Dr. Randy Vince Jr. I'm a urologic oncologist at University Hospitals, Case Western Reserve University. Just kind of my medical journey really quickly. Did medical school at Louisiana State University, LSU. Then I did my urology training at Virginia Commonwealth University in Richmond, Virginia. I did fellowship in urologic oncology at the University of Michigan, so if you got a boo to get out, go ahead and get it out. And to add to that, I'm from Baltimore, so I'm a huge Ravens fan, so you can get another boo in there if you want. But also, in addition to that fellowship, I did a master's in computational medicine and bioinformatics. So really the goal of that was being able to bridge this gap for a lot of the things that scientific terms and things like that, to be able to distill that down. So that way, you know, you don't have to have a master's to understand exactly what we're talking about. So to start off with, when we talk about prostate cancer incidence and mortality, and I'm sure you guys have probably heard this already today, but as you know, prostate cancer is the most commonly diagnosed solid organ cancer in this country amongst men year after year. And then when we look at the mortality, it accounts for it's the second most common cause of cancer deaths annually amongst men. And so with that being said, we start looking at why genetics matter. And, you know, over the last decade, when we talk about genetics and germline testing, somatic testing, genomics testing, it's really to help us with identifying people who have certain mutations that we can target, but also how their family history might play a part in informing the next generation. And so I'm not going to go through this study in great detail, but this was kind of one of the landmark studies for us in medicine, in which they found, when looking at multiple registries across the nation of men with metastatic prostate cancer, they found about 12% of men who had metastatic prostate cancer harbored a mutation in the gene that was passed down or hereditary. So multiple other studies have shown this similarly at rates to anywhere from 10 to 15%. And so with that, I want to just kind of step back and talk about what exactly is a mutation anyway. So oftentimes when you take biology class, they'll throw this term out, the central dogma. And all that is a fancy way of saying the process of our cells being developed and our tissues being developed goes from DNA to RNA, then to proteins. Those proteins are what our tissues are made of. And so, they kind of put this differently. If you imagine a cookbook with a bunch of recipes in it, step-by-step instructions on how you make a meal. So the cookbook is the DNA for us. So that provides all the instructions on how these proteins should be developed. And then if you want to make a specific protein, you take, just say, let's rip out a recipe from that cookbook. Let's say we're talking about chicken pot pie, right? Those details, that individual detailed information on how to make a chicken pot pie is now in the RNA. And then after you go ahead and combine the ingredients and make it and put it in the oven, and the final product is the chicken pot pie, and that's the protein. So that is what we're talking about, is DNA to RNA, RNA to protein. So that's the central dogma. So when we talk about genetic mutations, what we're talking about oftentimes when you hear these thrown out is there's some type of abnormality with the instructions at the DNA level. So ultimately, if you take out line number, 10 from that recipe book, then the final product won't be how it's designed initially to be, or you won't have that product at all. So that's what we're talking about. So hopefully that makes sense. So if we have some type of abnormality that develops with the DNA, it can alter the final product, or it can cause the final product not to be produced at all, okay? So when I was in med school, we heard this saying all the time. It says, genetics can load the gun, lifestyle pulls the trigger. And I say this to say that even if you have a germline mutation, which is the mutations that are inherited, it does not necessarily mean you'll develop the cancer. It just means you're at increased risk for developing that cancer. And depending on your lifestyle, that might accelerate that risk or elevate that risk, to put that differently. So let me go over germline versus somatic. And all of us in here are adults, so in order to have fertility, you need a sperm and an egg to come together. And then it develops into an embryo, and then we kind of go from there. So a germline mutation is a mutation that occurs before that embryo is developed. Okay, so that's how it's passed down from generation to generation. A somatic mutation is a mutation that occurs after the embryo is developed or after a person is born. So those are the mutations that, I don't want to say occur sporadically, but those are the things that are not necessarily passed down from generation to generation, where those germline mutations can be passed down from generation to generation. And so to say that differently, the way that we look at these things are a little bit different. So germline mutations, like we talked about, can increase your risk of developing certain cancers. And additionally, that can help inform the next generation around family history. And we can adjust screening depending on, if you have certain germline mutations, because that's different than what we recommend for everybody else. Whereas with these somatic mutations, they often alter how a cancer behaves. So to say that differently, sometimes the cancers behave more aggressively when you have somatic mutations. Then they can be treatment resistant and things like that. So that's the reason why we like to delineate between those two, because it helps us as physicians determine treatment, screening, and everything in between. So with that being said, let's talk about who should get genetic screening. And then I lifted this from NCCN, and we'll go through each one of these. So it's really 3 factors we look at: ancestry, the cancer characteristics, as well as your family history, okay? So when it comes to ancestry, Ashkenazi Jewish ancestry, they say you should undergo germline mutations, and part of that is because there are a number of genetic predispositions for that population of people, and so we want to start screening a little more earlier, screening earlier if these germline mutations exist. Next is the clinical features. So in the panel that was here before, they talked about how if you have metastatic cancer, we want to do germline testing. If you have high risk cancer, which is, we talk about risk, and I feel like we throw these terms out because we talk about them so often as physicians, and then, patients are like, what does that mean? So when we talk about risk, we're talking about from the time this cancer is diagnosed and it's confined to the prostate, risk is how likely is that cancer to spread outside the prostate if not treated. High-risk cancers tend to behave more aggressively, and so the chances of that turning from a cancer that's confined to the prostate to metastatic is a lot higher than somebody who has what we call low risk, okay? So when we talk about cancer features, we're talking about metastatic cancer, and that could be either spread to the lymph nodes or spread to other parts of the body, as well as the men with high risk or very high risk cancer. And again, I'll go back to this one where they saw, again, about 12% of men who have metastatic cancer had germline mutations. And then we talk about family history. So, if you have one close blood relative with the following, so diagnosis of breast cancer before the age of 50, we start thinking about things like the BRCA mutations, which you've probably heard of before. And that's both male, female breast cancer. Ovarian cancer is also kind of lumped in there. Pancreatic cancer or prostate cancer. And again, it's not just this low-risk prostate cancer, but if you have the aggressive forms. Or you have 3 or more close family relatives, close blood relatives. So what is a close blood relative? So again, I just took this from there. So if you have your parents, your siblings, right, and then any children who are ultimately diagnosed with cancer, those are first generation. Then you kind of start spreading out from there. So you're talking about grandparents, uncles, aunts, things like that. And those 3 are on the same side of the family. So that is highly indicative that gene mutation might be passed on from one generation to another. So why does this even matter? So again, it can influence how we screen patients and our propensity. So just give you a real clinical or real world situation. So if I have a gentleman who I know has a germline mutation, where NCCN might say screen everybody for prostate cancer starting at the age of 45, I'm going to screen him a lot earlier. So I'm probably going to start no later than the age of 40, checking his PSAs. Then you see these next two are MRI and a biopsy. My propensity to get an MRI, if I start to see increases in his PSA, or my threshold to get an MRI is going to be lower. So, I'm going to say, okay, yeah, we should get an MRI sooner because of that increased risk of developing cancer. And then ultimately, the chances of me taking him to do a biopsy to actually see what's going on with his prostate, again, that threshold is going to be lower. So that can alter the management or in terms of screening. Additionally, if you have somatic mutations, this is just how we, and I don't like talking about the Gleason score because I feel like it confuses people. So just talk about grade groups. So 1 through 5, 1 is low risk, 5 is high risk, okay? So if you have somatic mutations, the likelihood that you're falling on a more aggressive tumor biology is a lot higher than if you did not harbor that mutation. So again, that's how we impact screening and diagnosis. Now I'm gonna just go over treatment really quickly. So I put this here, and I don't get paid by Decipher, but when you look at all the guidelines, they probably have the most literature around the use of, now this is what we call genomics, so I'm not trying to confuse you guys. We talked about genetic gene sequencing in terms of somatic and germline mutations. Now we're talking about what we call transcriptome or genomic information. So again, I'm not paid by them. I'm not, I'm just using this as an example. So what they do is they sequence the whole transcriptome, which is all of the RNA to look at how the genes are expressed. So again, that's that second step from RNA to the proteins, right, that we talked about. And based off of 22 of those genes, they have like this little signature that they use, and they're able to give us information on how that cancer is likely to behave. So again, this is just one more additional piece of information that we can use to tailor treatment decisions to the patient rather than treating everybody as one size fits all, okay? So ultimately, I hope you guys can see this in the back, but it goes from low, intermediate to high risk. And when we see patients with high risk, we tend to treat them a little more aggressively because that tumor is likely to behave more aggressively, okay? So this is what I'm talking about in terms of transcriptome. So again, we're looking at that RNA that we talked about before it goes to proteins. And I put this here, oh my gosh, that's really small. I'm sorry, guys. So this is just NCCN guidelines on how we risk stratify people. Again, that risk, we're talking about what is the likelihood of that cancer moving from the prostate to other parts of the body. And then when we talk about treatment, this is just kind of a condensed form. What you can see is that low risk, we're talking about active surveillance. So that's not treatment, we're just watching. We're monitoring this actively, and if things seem to be progressing, then we can move on to treatment. But what you see is that when you go from low risk to intermediate to high risk, the treatment intensity increases. And so we can use genomic testing to, again, do precision medicine to tailor treatment directly to that patient instead of treating everybody one size fits all. And so these are just some of the examples that we could use it for. So in that low and favorable intermediate risk, if you have a high score, we can do more intense surveillance versus less intense surveillance. And that goes all the way down the board to determining LT is long-term androgen deprivation versus short-term. So even, I heard someone ask about hormonal therapy. The timing around the hormonal therapy can also be influenced. How many medications you ultimately end up on is also, it can be influenced by whether or not you have a high risk score or not. And then lastly, if you do have germline mutations in the metastatic prostate cancer space, a lot of patients respond better to this specific type of medication. It's called the PARP inhibitor. So again, I'm not putting this up here to kind of put you guys to sleep or anything, but this can, we can use these things, again, to tailor treatment to a specific man rather than, again, treating everybody as they one size fits all. So some key takeaways, I do think amongst families, because, I'll give myself as an example. I ask and ask and ask, but I have no idea, especially on my father's side of the family, about family history. Really, I don't have any idea about what things ran in the family versus what things didn't. Back in the day, that wasn't something that people talked about really, so I think we should be engaging in those conversations. If you do have a strong family history of cancer, I do recommend that you talk to a genetic counselor. They can go through what the process looks like, what are the implications for insurance and things like that. Genetic testing does not take the place of screening, right? So if you get genetic testing and it's negative, that does not mean that you shouldn't get screened for prostate cancer. Again, we're trying to gather as much information as possible so that way we can tailor treatment to you specifically. Definitely get screened because we have a number of men who are presenting with advanced prostate cancer when they come in, and so we want to get ahead of that. We want to catch cancer when it's just confined to the prostate so we can treat it. And again, I can't say this enough. Share your story, spread it to your loved ones. And then, if you are diagnosed with prostate cancer and you need treatment or any management options, talk to your doctor about the genomic testing to see, if that can help with tailoring your management plan. So I'm going to stop there. I always do this, so bear with me. I give thanks to my mom and my dad. You see that I lost my dad at 12, and I strive to be a man that he could be proud of. My mom instilled hard work and, the value of education in me, so I love them for everything they've done for me. And then lastly, gosh, I do this. Every time I've given a talk since April, I've put her in this, and it always chokes me up. I lost my sister very tragically in April 20th of this year. So she was one of my biggest cheerleaders, and so the life that I lead, I want to make sure not only am I honoring my parents, but I honor her as well. So so I'm going to stop there before I start getting too choked up. And then I'll take any questions you guys might have. Yes, sir.
What percentage of people with advanced prostate cancer get a benefit from genomic testing?
That's a tough question because not everybody gets it, all right? Just like even germline testing, while advanced prostate cancer, the recommendation is that you undergo genetic testing. The best places are doing it at 50%, and that's at the absolute, we see those numbers, we're like, wow, you guys are doing this really well, when it should be close to 100. So everybody else is kind of, 20s and teens in terms of, so it's hard to say how many men with advanced prostate cancer or the percentage of men that would benefit from that. But I do think it's a discussion that, that you should have because, as a patient, the job of us is to inform you of, the things, the tools that are out there. And so that's something that you can have a conversation with your physician about and whether or not that's beneficial for you. Absolutely.
I have a question. When you have a biopsy, how routine is it to send it out for genetic analysis? Or if you have the surgery, do you do genetic testing on the material?
So typically not the genetic. So when we talk about genetic testing, that's different than the genomics or precision medicine. So the genetic testing, we don't send the biopsy specimen off or, prostate specimen off for genetic testing. That's something that's different. But the precision medicine part around, genomics and things like that, we do send that tissue off to get a good reading and get information about.
You're finding that genomics testing is being covered more by insurance or
Yes.
both Medicare and, okay.
Yeah.
Any other?
We talk about genetic testing. Can I just waltz into the doctor's office and say, hey, look at my genes? I mean, how do we go about this?
So, yeah, I mean, you could go when you have a doctor's appointment. I think the one thing is, though, you have to tell them, like, hey, we have this propensity for X, and I would like to have genetic testing. And then they'll likely send you to a genetic counselor who kind of go through everything and then order it for you.
Another question?
Yes, sir.
Yes. My dad passed in 2003, and I don't know exactly what he passed from, but going back to one of your slides that listed the various types of cancers that may be indicative of whether you should get this type of testing. My mom passed 60 years ago, actually October 31st, 1965, of cervical cancer, and I just was curious as to if you had any more information as to why that wasn't on the screen as one of the major cancers that, was listed.
You're talking about this slide here.
Yes.
So the reason why these specific cancers are there is because these are cancers that are known to have a genetic association to prostate specifically. And cervical is not one of them. So, for instance, if someone has a BRCA mutation, there's a predisposition to breast cancer, ovarian cancer, and on the male side, also prostate. So that's why that shows up versus cervical cancer, which there's not saying there's no mutations that are associated with cervical cancer. They just have not been seen within the prostate cancer realm. Yes, sir.
I have a question. If somebody has a Gleason 9 and a defective repair gene, which puts them at high risk, the Decipher score came back intermediate risk. Which do you put more weight on, and how do you reconcile the fact that those two are so different?
Yeah, so if they have high-risk prostate cancer and an intermediate risk score on Decipher, you treat it as high-risk prostate cancer. I would not decrease intensity based off an intermediate reading from the Decipher score. So, say it again.
How are they so different? One is very high risk and one is intermediate.
Yeah, so I think for us, I can't answer why that will be different, but it does happen, where we see somebody who, by grade group, on that biopsy, it looks like this is a very aggressive cancer, and then we get a Decipher, and it's like intermediate. And intermediate is kind of that gray zone for me, right? It doesn't influence my decision-making one way or the other. It's more so low-risk, high-risk type of thing. So, but I can't speak to why those two would be different. But, it could be just the genes that they're using in the signature to give us that risk are not differentially expressed. Sorry, not trying to be too scientifically, but that's ultimately what it is. But I would treat that person as high-risk prostate cancer, and we would give them the same intensity of treatment. I would not de-escalate the treatment based off of that.
One last question before.
So do you foresee that with prostatectomies, it will send it out for Decipher tests in the future, all of them? Or why wouldn't they?
Yeah, so that's a great question. In terms of prostatectomies, it really depends on the pathology we get back as well as the PSAs afterwards, right? Because, again, that gives us an understanding of if there's cancer recurrence, how we should proceed in terms of treatment, right? So that is an additional piece of information we can use for that treatment decision. But not everybody who undergoes a prostatectomy is going to have cancer recurrence. So in those people, that test really wouldn't be beneficial. So I don't think it'll be a generalized, everybody gets a Decipher, but I think it will increase more and more as we go along.
All right, again, I know we can keep going on and on for all these sessions, which we can keep going much longer, but we want to keep things moving. Thank you again, Dr.
Absolutely.
Ritz. Appreciate your time.